Good afternoon, everybody. It's my great pleasure to welcome you on this COVID-19 webinar series supported by Geistlich Biomaterials. My name is Daniel Benson, and I recently had a few days ago a chat over the phone with Hazel when she asked me to take part in this webinar series, and I was really happy to accept her invitation. And I truly believe that in this difficult or challenging time, when all our profession hits a pause, it's a great opportunity to consider focusing, furthering our knowledge on dentistry, also to try to look into areas to build our where it's needed to build our confidence. So my part to bring to you in this presentation series is single tooth replacement and grafting. A little bit about my background. I'm a 2006 graduate from Semmelweis University. This is a university in my hometown Budapest, Hungary. After my undergraduate studies, my further education led me to focus on implant master courses, which led me to a Master of Science in implant dentistry and dental surgery. We live in a beautiful part of the world in Scotland, in Edinburgh, with my family, my wife, Orshi, my kid, Ollie, and Lillian. And my practice is based in city centre of Edinburgh. It's a new built private implant practice with a purpose-built clinic and lab. Our focus with our rehabilitations is mostly on full arch treatments, but we also see a large number of cases where single or multiple implants are needed. Also, we deliver high-end aesthetic restorative treatments as well. This is just a random slide about some of the last year's production. Postoperative CBCTs and X-rays are showing here, showing predominantly full arch restorations or graftless solutions. There are also some sinus grafts, immediate implant placements, and other treatment modalities like revision cases. Our typical all-on-4 immediate loading protocol is seen here. We believe that there is value in grafting the extraction sockets. The choice of graft material here, according to our protocol, is using xenogenic graft material like BioOS, with a mixture of autolog bone that is bone harvested actually from alveoloplasty. Once it's processed, it's crushed, it's mixed with BIOS, and then we fill up the sockets and the surrounding areas around our implants to maintain good long-term volume stability. Another part of dentistry that I enjoy the most is the anterior aesthetic cases, the smile makeover cases, where the transformation of the patients from a appointment to another, it just fills us with joy, and I really like to capture these moments. This is why, as well, I believe that today it is essential to have a dedicated photo studio in your office. Now, as a sideline, I like to teach photography, so I visit practices to give advice how they can spare some space and what equipments they really need to be able to deliver excellence in their everyday photography to capture their cases. Now let's go back after this short introduction to our topic today, single tooth replacement and grafting. You can see on the timeline here below the title is the classic ITI placement protocol that divides the 4 stages: immediate, early, and late implant placements. Why do we need to speak about grafting? Now, with any of these uh, treatment protocols or placement protocols, the reason for grafting is to maintain long-term success. Now, with my presentation, with my webinar today, I would like to bring 4 cases to you, an example for all these options, keeping in mind our goal is to achieve long-term tissue stability around our implants. And the magic number here, if you follow the delayed placement protocol, is minimum 2 millimeter of bone. If you do immediate placements, this number jumps up to 4 millimeter according to recent literature. The first case I would like to share with you is Peter's case. It's a late implant placement with contour grafting. Let me show you the occlusal view of his dentition pre-op implant placement. You can see a little bit of buccal dipping and contour loss. Now, also a little bit of occlusal trauma and parafunction, indicating some attention to our final restorative treatment that was addressed actually with a night guard, a splint therapy. So after raising a full thickness flap, you can appreciate the buccal contour. If reviewing these photos when I was doing this presentation, I considered that if I place my vertical incision line further away from the area, could have been a better result. But also, probably it's not a bad decision to keep it where it is, because you don't necessarily want to overexpose unnecessarily the root surface of the canine. So the implant placement following my drilling protocol still allowed me to maintain quite a good amount of buccal bone around the neck of the implant. Usually for implant positioning, we know our dimensions. We need to keep at least a millimeter and a half away from the mesial and distal neighboring teeth. So we achieved that using an implant positioning guide. It's a straightforward suck down guide that provides us enough dimension. Now, I've planned for subcrestal implant positioning. And I also plan to use healing abutment at this stage. Now, this bone profiler from Straumann is a really, really clever tool to use to match your bone dimensions according to the shape and contour of the healing abutment. Once the healing abutment is fitted over the implant, then we started actually proceeding with our grafting. So BioOS was used, laid over with BioGuide. You can see that around the palatal edge of the flap, I tugged the membrane under and secured it with some sutures. On the buccal aspect, titanium tacks have been used, master pins to be specific, and 2 weeks after, this is our healing, primary healing. 3 months later, the maturation of the soft tissue is just beautiful, and the postoperative CBCT shows the grafted volume around the buccal contour is just beautiful. We have good amount of keratinized tissue for our emergence profile, and this is our final restoration with screw retention. The occlusal screw access was sealed with some composite restoration, and this is our final control periapical X-ray. The next case I would like to bring to you is an early placement, where at the time of tooth extraction, I've done some socket preservation. Now, Diane had a vertical tooth fracture Unfortunately, we had to take out her tooth. Again, power function is obvious in her case. So after the careful removal of the tooth, we cleaned the socket and we filled the socket space with some bio-os. The bio-os was covered with mucograft, which is a soft tissue graft material, and it has been carefully sutured. It works as a lid to avoid loss of bone graft materials. After week 1, this is how it looks when the epithelial cells start to migrate over the surface of the mucograft. And at week 2, this is what you get with the unmatured soft tissue closure. Some popcorning of the graft material is visible there. Now, 4 months after the socket preservation, this is our CT scan result. I was really happy to see, of course, I can see some graft materials in islands still, but it is just a beautiful maintained buccal contour, which allowed us to plan for implant placement simultaneous with the healing abutment fit. Now, to make sure that the buccal contour of the soft tissue there is further enhanced, this is my incision. I've done a partial deepitalization in this area, and our usual implant positioning guide is visible here. After implant placement, I fitted the healing abutment, and you can see how, like the modified Pellucci technique, I've rolled under the edge the deepithelialized connective tissue there and secured it with some monofilament suture material. Our postoperative X-ray, and 3 months later, I was able to proceed with the restorative stages, and this is our final restoration. Again, the screw retained crown. She was really happy with the result, and the postoperative X-ray looked good as well. Now, for the next case, I would like to bring you a GBR, a guided bone regeneration case, which shows a failing, which shows a restoration of a failing upper right central. All these 4 anterior crowns on the upper arch, the patient didn't like them. She never had a good experience with her previous dental practice, unfortunately, and this led to a situation where she started neglecting her teeth a little bit. Now, until the point where actually this upper right center broke, biting on something hard. You can see the panoramic X-ray that shows the underfilled root treatment and the post crown in place. Now, looking at her X-ray, we actually developed a full arch, a full mouth rehabilitation with multiple root treatments, crowns, and fillings. But because this presentation is focusing on single tooth replacement with grafting, I would like to only focus sharing her case regarding the anterior segment. Now, because we needed time, at least a good 12 weeks for the inflammation and the buccal bone contours to settle, I needed something like an anchorage for the temporization. I've decided to do the re-treatment of the neighboring teeth on the left-hand side with some core and post and core build-ups. I've re-prepped the neighboring lateral incisor as well, and after the extraction, those 3 teeth served us as anchoring elements for the long-term temporal bridge. 12 weeks after the tooth extraction, this is how Andrea returned. You can see from the occlusal view that the buccal contour actually suffered. This time it was just enough for the tissue to resorb and settle. A few weeks later, we scheduled her in for a GBR procedure. This is a recording of her GBR procedure. I'm using here form stable membrane, a titanium mesh that I'm fixating with the titanium tacks. Actually, Meisinger master pins have been used for this case. You can see that the titanium mesh is easy to adapt to the contour and shape you would like to use. And this is definitely a positive property of that. What I'm using is Bios collagen, nicely firmly tucked under the form stable membrane. And you need to be aware of safety distance between the neighboring teeth. Again, further tacks are introduced to make sure that there is proper immobilization of that membrane. To prevent tissue, other cell migration in between the graft particles, a bioguide was laid over with a free connective tissue graft as well. So this is how everything was sutured after the procedure. You can see a little bit of exposure of the connective tissue graft. I'm using a 4-0 monofilament suture material, and I'm trying to avoid any dispositioning of the mucogingival junction in the area. Now look what happens in 3 weeks' time. There's a little bit of strangulation you can see on the ridge there from the thick suture material. So maybe I would choose for the same situation again, something more like a 5 or 6-0 or even PTFE suture material. And over the area where the pontic maintained contact with the ridge, with the healing, partially exposed connective tissue, we have a little bit of a delay on the wound healing. But by week 8, this is how everything looked. Beautiful light pink, firmly attached contours to the underlying bone. Partial exposure of the titanium mesh is something that we see quite often. It's not a big deal at all. And at week 16, after the GBR procedure, I was able to remove the mesh in one piece easily and place the implant. You can see that just in the crestal area, this is only a partial thickness flap elevation. We never needed anything more, and this area is actually a critical area. You don't want to raise a full thickness flap just to make sure to preserve your crestal bony peaks on the neighboring teeth as well. You can see the good primary stability that we have achieved, and the postoperative x-ray 12 weeks after the implant placement confirms nice integration. So then we proceeded on with our implant exposure, open tray impression to finalize treatment with individual crowns with palatal screw access. So this is where we started, and after 3 surgical procedures, tooth extraction, GBR, and implant placement, this is what we were able to achieve. Now, I believe there is a better solution for the same cases out there to try to consider immediate placement more and more for cases, just because our patients are getting difficult to keep motivated. Also, they want their solution right away. They don't want to suffer multiple times if they don't have to. So I believe that immediate implant placements are kind of more and more in the center of indication for these type of scenarios. But before I show you the case I would like to share with you on immediate placement, let me show you a parallel, a very similar case to that. Again, upper right missing center incisor in a thin tissue biotype. But in this case, I haven't used a form stable titanium mesh. I only used collagen membrane. So the flap design, the incision line was trapezoidal flap. We raised the full thickness flap, elevated the flap. There was a fenestration on the neighboring tooth root. We see that about 13% of the cases as an incidental finding. So after the flap elevation, in these cases, I recommend to continue and do your periosteal release incision and mobilize your flap for closure before you do your grafting. And after that, you can see the collagen membrane was again nicely fixated, firmly fixated to the underlying bone with titanium tacks. This is the membrane raised where I'm positioning the BIOS collagen graft material. Now, after the graft is secured again with our palatal tack. So 3 tacks, 3 sutures have been used to firmly hold down the collagen membrane in place. You can appreciate from the occlusive view how much volume we were able to gain. And this is the key, that the sutures and the tacks are helping to immobilize that graft material in place. Now, why it is necessary? Because most of the time, using no stabilization for our membranes, purely by closing the wound, you can compromise the final contours by almost 40%. I'll show you a study on that later on. But this is the end result 2 weeks right after the procedure. You can see the primary wound closure nicely achieved and the buccal tenting or contouring of the tissues is maintained. So this is the study I would like to share with you. It reaches back to 2015. Mira Murray showed a nice study that using granulated graft material with collagen membrane only at the time of suturing or closing your flaps with tight sutures, you can actually lose some of the volumes that you have created. So for that reason, there's 2 options you need to consider. One is to stabilize your membrane, and you can use pins, you can use membrane stabilization screws, or even sutures for that. That is recommended to maintain the volume. Or you can consider something like a block of graft material, something like the BIOS collagen. So after these staged protocols, let's see how would we manage an immediate case. Let me share Susan's story as an example here. Susan is a dental nurse. She was working with me on one of the part-time positions I had as a visiting implant dentist. Her case is about 4 or 5 years old now. I still keep a good connection with her, so I know that she's happy with her situation at this stage. But let me go through on the case with you and examine exactly what have happened. So she has a high lip line, a thin gingival biotype, and an anterior tooth in need to be replaced. What happened was, let me go back one slide. What happened was she had in her teenage years some trauma on the upper left central incisor, and she had to have root treatment. After having the root treatment, the tooth started to get discolored. When she started working as a dental nurse, her previous dentist provided her with a post-retained crown. Now, what happened was she started feeling some awkward tingling sensation from the area, some itching. She knew that something was off. She asked us to take a CBCT, and this way we discovered that there is external bone resorption on the tooth. Now, on this CBCT section of you can see the buccal bone volume is almost non-existent, just paper thin. You can see the shape and the inclination of the premaxilla, the bone, and also you can see the the incisive canal behind the tooth is closely located. At that stage, I didn't know about southern implants and their coaxis solution. We neither had Inverta as an option for us. So even prior to her treatment started, we agreed that, well, it needs to be a cemented restoration, and she was okay with that. So it is really nice to work with somebody dentally aware. So even before we started her case, we went through on some of the important features to underline where is our starting point. For this description to be objective, I usually recommend to use the pink aesthetic score and the white aesthetic score. You can see that there is already recession on the 2-1, and the distal papilla is slightly under the favorable position. Now, we set up a team for the treatment of her. Everything went on the sedation on a Saturday morning, speaking about the VIP. So all the focus was on her for the full morning. My game plan was to start with the connective tissue harvesting. You can see our operator here. The palatal flap was then sutured. I usually use different type of suturing technique. I don't use that anymore, just to keep less knots, less disturbance for the tongue. And also you can appreciate how much tissue we have gained, we have removed from the palate. After the connective tissue part, we went to harvest some outer bone shavings. It's important because this provides osteogenic potential for our graft or grafted bone. Also, I prefer to fill the jump gap in layers. The first layer that is in contact with your implant surface, I usually recommend to use only native bone, and then a mixture of bio-os with alveolar bone harvested from shavings. So after getting the bone and soft tissue ready, we moved on to a partial thickness flap preparation, a tunnel preparation, which is creating a pouch for our connective tissue. For that, I'm using the microblade and tunnel preparation instruments. You can see that this is a very fine, delicate instrument that allows you to carefully manipulate the tissues. Now, once the tissue is mobilized, I have been able to remove the tooth, remove all the scar tissue around it. Our drilling protocol was straightforward, working on the palatal aspect of the bone. The implant again was fitted. It wasn't the coaxis at this time. I was using a different Straumann VLT implant. Sometimes even in very limited bone, you can achieve with good drilling protocol high primary stability, so you can actually immediately load, immediately restore, but of course defer loading, but immediate restoration needs to be presented on these cases for multiple reasons, to work on the emergence profile as well, and to make sure that the aesthetics of the patient is addressed. So you can see the connective tissue in place, laid over the area, and then tugged under the gum contours and secured and fixated by 6 sutures. This is our temporary cylinder, and you can already see how much boosting of the soft tissue we were able to create with that connective tissue graft. Finally, the suturing, only 4 stitches have been used in this area, 2 vertical stitches helping to keep the position of the soft tissue margins close and further down than the original situation was. This is our postoperative X-ray and CBCT. Please appreciate that even though I mentioned 4 millimeter of buccal bone volume as long-term stable, but the thing is, this is an outlier case. This is a thin tissue biotype, and also even the jump gap after implant placement haven't allowed me to place more than what you can see of graft material there. Now, there could have been another option to raise a buccal flap, a trapezoidal flap, and do buccal contouring as well. But we decided to keep things minimal and slick, and to avoid having any scarring on the facial because of the higher lip line. I decided to further protect our close to 2 millimeter, 2+ millimeter grafting on the buccal aspect with some connective tissue grafting. So this is how everything has healed around week 6. I was really happy with the bone level, with the soft tissue level around the temporary crown, and you can see the buccal contours again, very nice, firm, thick tissue, and good emergence profile as well. So our final result is this. Now, she was able to get married. She was really happy with the result. But I always felt that actually we could achieve a nicer result if we go back just one more time with the small soft tissue graft, maybe harvesting from the tuber area. I offered that to her, but believe it or not, she was so happy with the result. And this is just kind of indicates again that our patients are really looking for a one-stop shop to have everything maybe on the same day of tooth extraction, immediate placement. Immediacy is really something that our patients are looking for. So she decided not to go. She was happy with the result. And with this case, I would like to thank you for your attention on this webinar. I would like to encourage everybody to try to stay positive, stay safe, and stay positive. Try to consider that this is a time where we can look at things slightly differently. Try to concentrate on the positives. The glass is actually half full. Let's be grateful for time we can spend home with our families, the time we can spend on further educating ourselves, and you know, sooner or later we will be back, and we just get started again, even stronger, even better. Now, thank you once more for your attention, and for Geistlich to provide me a platform to share my cases. If you have any questions, please contact me on any of the following contacts or right below. Thank you very much. Bye-bye.